Hello, I'm Dr. Maureen Markman from City of Hope, and I would like to briefly continue the conversation we started last session. Where we're talking about ethical considerations in clinical research and get to more contemporary concerns. Clearly, the complexities of research, the requirements for optimal research have the potential to be in conflict with what we might consider optimal patient care, or very importantly, the doctor-patient relationship. Questions of the use of placebos, the ethics of the use of placebos. Clearly, we could say, well, from a pure scientific perspective, if one group was getting a placebo, you can compare that to an active therapy, because then the doctor and the patient wouldn't know what they were receiving. You could say, well, scientifically, isn't this a good way of doing it? One could perhaps make the argument in certain settings, but in the other setting is, are you denying the patient an opportunity for a therapy, even if we don't have terribly effective therapies? This came to the forefront in the conversation about treatment of AIDS and the use of therapies, for example, outside the United States that might not have been available in the United States, but in other countries. Were you providing the best available therapy, even if that therapy would not have been available standard of care? Within the research component, is it ethical to give placebos? Enough on that discussion, because in cancer, we haven't used that often, but we still run into the problem of cancer of phase 1, phase 2 trials being conducted. Very exciting, very impressive results. High response rates, time to disease progression, evidence of prolonged survival compared to historical controls. But if the definitive answer to the question is a randomized phase 3 trial, then what is the ethics of the conduct of that trial for the patient randomized to a control arm? The control arm here doesn't necessarily have to be placebo, but it might be, again, a standard of care that we recognize based upon the experimental data before us is inadequate. This became a very poignant discussion with the data on the targeted therapy of advanced melanoma many years ago. Randomized controlled trials were conducted. Previously conducted phase 2 studies of targeted therapies with BRAF inhibitors demonstrated extraordinarily high response rates, time to disease progression, compared to what we saw with a standard of care drug at that point, DTIC, which I recognize as being essentially of no value. The question came up, okay, patients could be randomized to an experimental arm versus a standard of care arm, but how about a crossover? How about allowing the patients, once the therapy has been shown to be ineffective in that individual patient in the control arm, allowing them to cross over to an exciting experimental arm? In the original studies of these targeted therapies in melanoma, crossover was not permitted. Why? Because the goal was to see the impact of the therapy and overall survival. And one can understand that if crossover had occurred, and we have lots of examples of this, that perhaps at the end of the day, the outcome would have been good for both groups, but you couldn't have shown a difference in the trial and in overall survival. And that's how the studies were conducted, in a very powerful reporting. New York Times reporter reported the experience of actually 2 cousins who had melanoma, one who had received the targeted therapy, one who received the control arm, and what they were going on the control arm. You can only imagine what the end result was. The question is, what is the ethics of allowing such a trial to be conducted in the United States? This question of the difference between clinical care, doing what's best for the patient, versus clinical research is a tension. Individuals such as myself argue there should never be a distinction. You will always do what's best for the patient. In a very poignant essay, the eminent physician, oncologist, radiation oncologist Sam Hellman in the New England Journal of Medicine argued for the critical importance of equipoise by that individual doctor for that individual patient in deciding whether a patient should be entered in a randomized trial. If the doctor felt that she or he could legitimately say one arm of the study is equivalent to the other arm, as far as I know, my interpretation of the data that's available, it's acceptable to recommend or suggest to the patient, if they're interested, participation in the trial. But if that doctor says, no, that study would not be acceptable to me, remembering the Nuremberg Code, would you participate in this study? Would you have one of your loved ones participate in this study to get a therapy which you believe is inadequate? Even though that's the study question, is it ethical to recommend your patients participate in this trial? Again, one might say, well, the academic research question is separate from what you do as a physician. And again, I would argue that is not acceptable to me. And I would challenge anyone who says that there are differences. What you do, what you recommend is based on what you feel might be in the best interest for your patient. There's sort of an poignant example in the lay press about this particular issue. Somewhat it's funny, but it emphasizes the point. Morris Abraham, who was a well-known lawyer, civil rights activist, and college president, in his autobiography written several decades ago, entitled The Day is Short, actually a very impressive book, describes the experience of his daughter. He had leukemia. Describes the experience of his daughter confronting the eminent lay physician James Holland, who was involved in the case. And his daughter pressed Dr. Holland for recommendation of why he was making a certain recommendation for her father. And Dr. Holland's response, as quoted in this book, was, "My duty is to advise. You must bear in mind, I am not your father's physician. I am an investigator." Honest with the statement, but the question is, what is in the best interest of the patient? And in my opinion, that needs to be always considered, not what is the best trial to put this patient on as the primary consideration. And I thank you for your attention.